Hi, I'm Ed Hope, a junior doctor in the UK, and welcome to Sick Notes, where I explain medical things in simple terms. Now, I've had an absolute blast looking at medical TV dramas, and you guys seem to really enjoy them too. By far the most common comment I get on the channel is, can I review Grey's Anatomy? So here it is. The reason why I've sort of been putting it off is that I never actually saw the show first time round. The other TV shows I reviewed, like Scrubs and House, I pretty much saw every episode of. Because I don't know it, please don't pick me up on little minutiae that I might get wrong, because I have no idea where this show's going. But maybe you guys will enjoy, sort of reliving it vicariously through my eyes. So we're going to take a light-hearted look at the first episode. Clearly it's a drama, so that's going to take the priority, so I'm not expecting it to be 100% accurate. It's just a fun way to talk about medicine and to revisit the show. So let's get cracking. So this is Meredith Grey, the main character in the show, and her first day of work. So far, it's a bit more 50 Shades of Grey rather than Grey's Anatomy. I mean, your first day as a doctor is extremely stressful. I wouldn't imagine anyone would party quite as hard as that on the day before. You'd probably party like that maybe on the last day of your first week. And when she arrives, she gets a kind of pep talk from one of the consultant doctors.
A month ago, you were in med school being taught by doctors. Today, you are the doctors.
Yes, you are the doctor. This is so true. I mentioned this in my Scrubs review. So many things are the same at med school. Kind of like the hours you do, the environment, most of the jobs you do actually. But it's only when you get that certificate and have that responsibility that you ultimately fill the shoes and feel the fear. These pep talks certainly happen in real life. I remember several of them when I started each job. In fact, even one as a surgeon.
The 7 years you spend here as a surgical resident will be the best and worst of your life.
It is the best and worst days of your life. Certainly for me, it wasn't the worst days of my life. Whatever job you do, you end up spending 40, 50, 60 plus hours a week doing that job. So it ends up meaning something to you. So any of the lows can impact you. My previous job in advertising I actually found a lot more stressful because I kind of felt like a lot of the stresses weren't really real. At least in medicine, when things are stressful, there's more of an impact and they feel more real, and I found that easier to deal with the lows so much. Regardless, nothing quite beats the highs. So they then all meet their colleagues for the first time.
Only 6 women out of 20.
Yeah. I hear one of them's a model.
I think there are still fewer women in surgical specialties, but medicine as a whole in the UK is actually more female doctors graduating than male doctors. I've mentioned this before in other videos. In the UK and many parts of the world, we don't wear white coats. People wear white coats to protect themselves from sort of bodily fluids and dirt and things like that, and also to signify who the doctor is. But we don't wear them because it's an infection risk, because you can wash your hands before and after every time you see a patient, but you can't wash your coat. So that's the reason why we don't wear them. This character, OMalley, sounds pretty funny actually. It's weird not knowing any of the characters and talking about them, yet you guys at home know exactly what's going to happen to them. So they meet their resident, so one of their bosses, who has a nickname of the Nazi, kind of not what you want on your first day. To be honest, this is pretty accurate, but I can totally see it from a resident and consultant point of view. In the UK, us juniors tend to rotate round every 4 to 6 months. So imagine trying to instill a culture, a team, and a way you like to do things every few months. As soon as the team have got it, they move on. It must be pretty frustrating. So I think it's actually a benefit to sort of have a regimented way of doing things, and you just keep doing that, and people just have to fit in the best they can. Ultimately, it's the consultants that are responsible for the patient, so it makes your job as a junior a little bit less stressful. You've just got to be the eyes and ears and make sure the plans happen.
Your interns, grunts, nobodies, bottom of the surgical food chain. Run labs, write orders, work every second night until you drop, and don't complain.
Don't complain. That's exactly what I said.
If I'm sleeping, don't wake me unless your patient is actually dying.
There's a semi-serious point to this. On a night shift, if anything can wait till the morning, we wait, just because there's less people around and it's less safe. So on a night shift, it's all about just keeping people safe. I'm already predicting that someone is going to get jiggy in this on-call room. Maybe not in this episode, but at some point. You guys know I'm right. So the team get interrupted when a patient arrives on the air ambulance. In reality, the patient would first go to the emergency department for assessment and initial management, and then handed over to the accepting team based, on the problem they have. Clearly, the writers have a bit of a creative license because they want a little bit more drama, so they want the new team assisting on the transfer. But yeah, this wouldn't happen in reality.
All right, get on the side. Izzy, 10 milligrams diazepam IM. No, the white lead is on the right. Righty, whitey, smoke over fire.
So this shows why emergency departments is the first place to go. In the UK, we don't have people on their first year in the emergency department for exactly this reason. So the patient has come in having seizures on and off for the last week. I would say that this presenting complaint would normally go to the medical team rather than the surgical team. And when you first see a seizure, it's actually really unnerving because it's so overtly shocking. However, the initial management is actually pretty simple, and although they're the surgical team, they do a pretty good job. So we put the patient into the recovery position.
Get on the side.
We make sure they can breathe properly, so we put some oxygen on. We also make sure someone's scribing and timing everything because we escalate the drugs and the dose of the drugs if the seizure doesn't stop.
10 milligrams diazepam IM. No, the white lead is on the right. Righty, whitey, smoke over fire.
So white is on the right, smoke over fire. I've not heard this before, but the resident is schooling Dr. Grey on where to place the telemetry leads based on a kind of memory aid. This is pretty realistic. You hear a lot of funny memory aids in medicine, can kind of get you into trouble, particularly when you're listening to the heart valves with a stethoscope. So you might accidentally end up mumbling to the patient, "All prostitutes take money." Looks like the diazepam has worked. We then look for a cause of the seizures.
Tox screen. Christina, you're on labs. George, patient workups. Meredith, get Katie for a CT.
Wait, what about me?
Honey, you get to do rectal exams.
As a surgical doctor, you do a lot of rectal examinations. It's funny doing this session with the medical students. I have to demonstrate how to perform a rectal examination on this kind of giant Action Man bottom, which I always then get quizzed on. It's kind of embarrassing, but it is always a fun session. As a doctor though, we need to get over being self-conscious very quickly because it's a really important examination. It can help with the assessment of bowel obstruction, constipation, prostate problems, rectal bleeding, or problems with the spine. But you don't normally have just one person doing that one job all day. That's pretty mean, although you do have days where, you always seem to get the bad jobs, but it's never normally quite this extreme.
Okay, so I'm just gonna insert my fingers.
Also, fingers, we normally use just one finger, but maybe this is highlighting, us getting nervous and self-conscious and accidentally saying the wrong thing, which certainly happens. We normally have the patient on their side as well. I don't know why I'm telling you this, not like you're gonna start doing this stuff at home. It's lunchtime, pretty well deserved break. The team end up talking about Dr. Grey's mum, Alice Grey, who's apparently a famous surgeon. Nepotism in medicine is very real. No one in my family was a doctor, and that made it quite difficult to kind of get a realistic idea. I didn't have anyone really to talk about, and also made it difficult to kind of get work experience. I was actually very lucky. If you think there's barriers there, you really just have to kind of explore those opportunities and find every single thing you can get. Also, lots of people asking me about the book that's always up here. So this is Grey's Anatomy. So this is actually not about Grey's Anatomy, the show, but it's actually a really useful medical textbook for learning all the anatomy as a student. So presumably that's where the show got its name. So then the parents of the patient start quizzing Dr. Grey, and this is definitely something I can relate to during my first week. It kind of goes back to me talking about being the doctor on your first day. You kind of get this imposter syndrome and feel like, should I really be talking about these things? Because it's so instilled in you as a medical student that you shouldn't be having these conversations. And then suddenly a few weeks later you're a doctor and it is your very job to be dealing with this stuff. We always tend to check with a patient that they're happy for us to share information with their parents and other people involved. And the trick is really in this situation just to listen to the concerns. Very often we can't give all the information, but it can be reassuring to find out what we've ruled out, what we've done so far, and what we plan to do in the future. Very often if you don't know things. Patients and relatives, you know, are fairly accepting of this. So the new consultant is the guy she slept with last night. I probably should have seen that coming actually, because I did recognise the guy, so presumably he's going to be in a lot of the show. In hospitals, I'm personally not very good at picking up on gossip, and then you just hear about something that's happened between two people and you're like, whoa.
I was drunk, vulnerable, and good looking, and you took advantage.
Okay, I was the one who was drunk.
Both claiming to be drunk before a shift. This is very bad behaviour. Before you become a doctor in the UK, you have to sit a test called the situational judgment test, and you are 100% guaranteed to get a question on whether it's okay to go out and get drunk before a shift. Spoilers for the answer now. The answer is don't do it. So one of the team gets selected to perform the first procedure. I think this is pretty mad. This may well be a difference between the US and the UK system, but I'm thinking probably not. Firstly, I've never seen these kind of galleries in theatres. I'm sure they still exist, so these viewing rooms where everyone can see. They probably exist in sort of large teaching institutions, but most places I've been to just have a little operating suite. Although we still call them theatres because kind of historically operations would be performed with kind of this kind of amphitheatre with lots of people watching. So having an intern leading the operation on this first day sounds pretty far-fetched to me. If you're in the US system and this has happened to you, please comment below, but I'm pretty sure this is pretty mad. But certainly in the UK, your first operation can happen on your first day, but you're just going to be assisting. So, you know, using some retractors or perhaps doing some suction, maybe even putting in a stitch here and there. I mean, I was nervous enough just putting my gown on during my first week. You may laugh, but I'm not kidding. It's actually really fiddly to, you know, put on the gown and gloves so you don't de-sterilise yourself.
You start digging for those purse strings before she bleeds to death. Bucky, give him a clamp.
BP's dropping.
Inevitably, the operation goes wrong. I mean, I told you they shouldn't be doing it. That's the point, isn't it? That they were throwing them in at the deep end. But just a couple of things I picked up. The first, blood pressure doesn't tend to drop that quickly unless someone's hosing blood out. And also for an appendectomy, we usually do it laparoscopically, so keyhole surgery, just so we're not making a large incision.
007. 007, yep.
A total 007.
007 mean?
License to kill.
007. I've not heard that one before, surprisingly. That's pretty harsh, although we do tend to hear a lot of nicknames flying around. I remember at med school there was all sorts of ones. I mean, I had a guy that only ever wore orange. I remember also saying to one of my colleagues, you know, I'm glad that I don't have a nickname, and they said to me, no, you do have a nickname. I was like, what the hell is that? And they said, you're trousers too short guy. Because apparently, like, one day, one of my smart trousers were a little bit shorter than they should be. Blimey. So Dr. Grey gets called to emergency. I talked about before how daunting seizures are. So on your first day as well, I mean, the first seizure I witnessed where I was kind of on my own was after a few months of doing the job. And that was super daunting. Just to reassure people, I've never heard of anyone having a cardiac arrest after a seizure, but it is a known but very rare complication, and people are not quite sure why it happens. So when the seizure stops, your heart rate can drop, what we call a bradycardia. People think it might be related to this because it can sometimes cause asystole, which is a type of cardiac arrest where there's no electrical activity of the heart. We don't tend to have much evidence on these things because they're a potential fatal thing that is difficult to do proper research on it. So all this has some kind of basis on reality, although it gets less realistic from here. Firstly, when someone is having a seizure, all the jerkiness means we can't get a good trace on the heart when it's happening. And secondly, when the patient goes into cardiac arrest, it goes into asystole, so where there's no electrical activity of the heart that we talked about earlier. And this rhythm does not respond to defibrillation, so Dr. Grey shouldn't be using the defibrillator here. So the team should just be continuing CPR and giving adrenaline. We then see a bit of little reflective moment where Dr. Yang is suturing a banana. I've actually done this. It's quite a good thing to practice on. So going back to Dr. Grey's patient, the lady that's having the seizures, the consultant sets them all a challenge to figure out what's causing the seizures. And Dr. Grey and Dr. Yang bang heads and they come up with the diagnosis of a subarachnoid hemorrhage. I quite like this diagnosis for a couple of reasons. Number one, it's not super uncommon. I've seen it a few times myself. And if you ask any doctor what the most common symptom is, it's a sudden onset severe headache. We call it a thunderclap headache, and it feels like you've been whacked over the back of the head. Although this isn't present in 5 to 10% of patients. So this explains in this patient why it wasn't considered straight away. It does cause seizures and the CT scan can be normal. So it's normally sensitive in around about 95% of patients. But if the bleed's been going on for a long amount of time, it can make the scan less likely to pick it up. And in our patient, it's been going on for around about a week. So what is a subarachnoid hemorrhage? Well, I'm going to tell you all about it. So this cauliflower is going to be our brain, and we have our skull. The brain has a bunch of membranes around them called the meninges. You may have heard of these in meningitis, where these membranes get inflamed. You can get a bleed within these membranes because blood vessels pass through them. One of these bleeds is called a subarachnoid hemorrhage. So our three membranes are the pia, which is a delicate innermost layer, the arachnoid, and the dura, the tough outer layer. And these are the blood vessels that pass between them. So the first membrane is the pia, which is this delicate layer that goes right around the brain, and it passes all the way around the spinal cord as well. So all the membranes do this. So the next layer is the arachnoid. It's called the arachnoid because it's got all these spidery connective tissue strands that reach out. Between the pia and the arachnoid, there is a subarachnoid space which has fluid in it called cerebrospinous fluid. We also have blood vessels in it. So these blood vessels go in the subarachnoid space, and then our arachnoid layer goes round, again all the way down the spinal cord. Finally, we have the dura mater, so dura because it's durable. So our brain and meninges are ready to go back in our skull. So in a subarachnoid hemorrhage, that is where one of the cerebral arteries within the subarachnoid space becomes damaged, normally from a trauma, so a head injury, or sometimes an aneurysm burst. So an aneurysm is a kind of bulging due to a weakness of the blood vessel. So in the patient in Grey's Anatomy, they actually had both of these things. And the blood will collect within this subarachnoid space because it's stuck between the membranes of the pia and the arachnoid. So the patient in this episode described having a fall.
And I tripped over my ribbon.
And also having this fullness in her head.
But I can't sleep. My head's all full.
So usually a scan would be able to see this blood accumulating in the subarachnoid space. If the CT scan is normal, we can do what's called a lumbar puncture, where we pass a needle within the back. As I said, these membranes go all the way down the spine. So we pass a needle that goes through the skin and soft tissues, through the ligaments and between the vertebrae in the back. It goes through the dura, through the arachnoid layer, and we sample a little bit of the cerebrospinal fluid to see if there's any blood within it. And then occasionally we use angiography, where we put dye within the blood vessels. So when we take a photo, we can see where the dye is leaking out, and if necessary, we can then repair the aneurysm. The reason why I'm not saying any more is because I actually don't know much more about it. I'm sure someone in the comments will fill you in, or you can check out some other videos about it online. So she's made it through her first shift and she visits her mum. Man, this was a pretty heartbreaking. I mean, I didn't see this coming. So her mum, this amazing surgeon, looks to have early onset Alzheimer's disease.
Are you the doctor? No. I'm not your doctor. But I am a doctor.
I've met lots of people with varying degrees of dementia whilst working in a hospital, and at first I found it extremely uncomfortable. I just didn't really know what to talk to them about, because they'd often ask to see their mum, who clearly their mum was no longer around, or they thought they were, you know, on a cruise ship and things like that. The best piece of advice I ever got was when someone told me that although their memories may be fading, that their emotional needs are still there. So when someone with dementia is asking, you know, that they want their mum, they don't actually kind of want their mum. They really are saying that they feel lonely and they feel like they want to talk to someone. And as soon as I kind of understood that, I felt a lot more comfortable providing care and being around people with dementia. So that's the end of the first episode of Grey's Anatomy. You know, I was pretty worried that it may have dated. I mean, this is going back to 2005. That's pretty mad, isn't it? But actually, I actually quite enjoyed it. I can see why it's had so many series. Clearly this is going for a much more dramatic approach to storytelling in hospital. So there's lots of inaccuracies, but I think lots of the stuff they were accurate about I could totally relate to. Things like suturing the banana and the initial handling of the seizure, and things like the memory aids that we use to remember medical things. I thought they were all nice touches. So thank you to everyone that suggested I take a look at this. I had a blast looking at it. To everyone else, thank you for watching. I'm still overwhelmed by all the subscribers and all the support and all the comments. Keep them coming. I'll try my best to provide content. Check out my other videos if you like them, and goodbye.